Hello dear viewers. After discussing sedation and analgesia in ICU patient in my last few videos, in this video I am going to discuss usage of neuromuscular blocking agent in ICU. We will discuss all the relevant aspects of its use. I am Dr. Sunil Garg from Essentials of Acute Care. Neuromuscular blocking agents paralyze skeletal muscle by blocking the transmission of nerve impulses at the myoneural junction. Remember, they do not block smooth muscles. These agents block the binding of the acetylcholine to the motor end plate, and they are divided into depolarizing or non-depolarizing agent based upon their mechanism of action. Depolarizing agents bind to the nicotinic cholinergic receptor on the motor end plate, causing initial depolarization followed by blockade of neuromuscular transmission, while non-depolarizing agents competitively inhibit the acetylcholine receptor on the motor end plate. Succinylcholine is the only depolarizing agent and is utilized almost exclusively to facilitate intubation or treat laryngospasm. Succinylcholine is not used for continuous infusion. Non-depolarizing agents are divided into aminosteroid compound, for example, vecuronium and rocuronium, and benzyl isoquinolinum compound, for example, atracurium and cis-atracurium. With regards to their usage, these agents are used for severe refractory or life-threatening hypoxemia, particularly those associated with severe ventilator dysynchrony. These agents may help to achieve lung protective ventilation through the prevention of spontaneous respiratory efforts and by reducing oxygen consumption through decreased work of breathing and abolishing resting muscle tone. They may also prevent injurious regional lung overinflation and dynamic hyperinflation. They are also used for the overt shivering due to therapeutic hypothermia following cardiac arrest. They are also indicated for eliminating unwanted movement or reducing muscle tone in patients with refractory status asthmaticus, patients with the raised intracranial pressure who have unwanted muscle movement, or ventilator dysynchrony contributing to raised intracranial pressure, patients with massive hemoptysis to prevent coughing and clot dislodgement, patients with condition that increases muscle activity, for example, patient of tetanus or malignant neuroleptic syndrome, patient with the increased intra-abdominal pressure, or patient who need temporary paralysis to facilitate short procedures like bronchoscopy, endoscopy, tracheostomy, or radiological interventions. When these agents should not be used preferentially. These agents are not the first line agent for managing undesired movements, agitation, or ventilator dysynchrony since they do not have sedative, amnestic, or analgesic property. These agents for these indications are generally reserved for patients in whom conventional strategy of sedation and analgesia have failed. They should not be used for the management of status epilepticus unless necessary for intubation or short-term ventilator management since they may mask electrical seizure activity. However, if risk of rhabdomyolysis is high, subsequent to convulsive activity and with ongoing continuous EEG monitoring, these agents can be used, and this is what we do in our ICU. With regards to agent selection, there is paucity of the evidence to guide clinicians regarding agent selection in critically ill patient. The choice between agents in ICU depends on both the indication and the patient's comorbidities, mostly the presence or absence of kidney failure, liver failure, and hyperkalemia. For continuous infusion, cis-atracurium is typically the preferred agent since the metabolism is unrelated to kidney or hepatic function. For endotracheal intubation in the ICU, rocuronium is commonly used as an alternative to succinylcholine given its rapid onset and intermediate duration of action, but without the high potential for hyperkalemia in the critically ill population. Succinylcholine should not be used in those with hyperkalemia since it may worsen hyperkalemia and potentially precipitate cardiac arrest. Agent selection in obese patient should be similar to non-obese patient. However, dosing may be different. There is no preference for one particular agent in patients with sepsis. However, critically ill patients with severe sepsis may have a delayed and reduced response to standard dosing regime of cis-atracurium. There is no preference for one single agent in patients with the hypothermia, but hypothermia may prolong the duration of action of all non-depolarizing neuromuscular blocking agent. Hypokalemia may augment the blockade induced by the non-depolarizing agents. Magnesium prolongs the duration of neuromuscular blockade. In contrast, hypercalcemia decreases the duration of neuromuscular blockade. The blockade effect of non-depolarizing agents may be enhanced by both respiratory and metabolic acidosis. NMPA or neuromuscular blocking agent can be administered by intermittent intravenous injection or continuous infusion. Succinylcholine is generally only used for intubation or laryngospasm. It is administered as a bolus dose only. Generally speaking, bolus dose of long-acting agent like rocuronium is preferred when transient paralysis is needed, for example for emergent intubation, while infusion of shorter-acting agent like cis-atracurium are generally chosen when sustained paralysis is needed. Specific condition may affect the pharmacokinetics. For example, reduced dosage may be sufficient in patient with myasthenia gravis or other muscle weakness disorder. In contrast, dosage of neuromuscular blocking agent must be increased in burn patient. Several drugs may interact with these agents which may make dosing adjustment necessary. Aminoglycosides, amphotericin, colistin, polymyxin, clindamycin, calcium channel blocker and low dose loop diuretics all increase neuromuscular blocker effect of these agents. The optimal level of paralysis for critically ill patient depends on the indication. Complete means 100% neuromuscular blockade may not be necessary many a times. It is more appropriate to think in terms of controlling motor activity rather than completely paralyzing the patient. Monitor the degree of neuromuscular blockade with regular clinical assessment, like for example observing ventilator triggering, degree of shivering, and peripheral nerve stimulation using train of 4 counts or tetanic stimulation. The dose can be adjusted to the desired level as necessary. For some indications, for example, severe ventilator dyssynchrony following intubation, 1 or 2 bolus dosage of a paralytic agent may be all that is required, while for other indication an infusion is needed, for example shivering. Similar to sedative infusion, daily interruption of the NMBH infusion is suggested to assess the ongoing need for paralysis. Discontinuation should occur as early as is feasible to potentially decrease the incidence of prolonged recovery secondary to drug and metabolite accumulation and to potentially decrease the incidence of neuromuscular weakness related to critical illness. Tapering the dose is not necessary when neuromuscular blockade is discontinued. Sedation and analgesia adequate for patient comfort must be maintained during discontinuation. The action of non-depolarizing agents can be reversed if necessary by administration of anticholinesterase drug such as neostigmine or adroponium. The action of the steroidal agents like rocuronium or vecuronium can be reversed by administration of sugammadex sodium. Patients receiving paralytic agent require meticulous care because the potential for complication is great. Adequate sedation and analgesia prior to, during, and following discontinuation of paralysis should be given. Processed electroencephalography monitoring, for example bispectral index, may be beneficial for assessing and controlling sedation during therapeutic musculoskeletal paralysis, as in these circumstances, sedation scales cannot be used. To prevent corneal injury, lubricating eye drops or gel should be instilled every 2 to 4 hours and eyelids should be taped shut to prevent corneal drying, ulceration, infection and scarring. Close monitoring for ventilator disconnect should be in place and ventilator alarm should be turned on. The endotracheal tube should be suctioned frequently to remove accumulated secretion, as these agents inhibit the cuff reflex. To prevent screen breakdown and decubitus ulcer, paralyzed patients should be turned frequently and kept on dry, wrinkle-free bedding. Paralyzed patients are at high risk of venous thromboembolism, so prophylaxis, either pharmacological or mechanical or both, should be given. Pupillary reflexes should be closely monitored to assess neurological status. With regards to adverse effects, neuromuscular blocking agents are the most common cause of anaphylaxis, immunoglobulin E mediated in the perioperative period, with succinylcholine and rocuronium being the most frequent agents implicated. The cross-reactivity between different agents is observed in more than 60% of the cases. The cardiovascular side effects, particularly hypotension, is associated with non-depolarizing agents and they are related to stimulation or blockade of the autonomic nervous system and vasodilation due to histamine release. The drugs with the lowest risk of cardiovascular complications are cis-atracurium, rocuronium and vacuronium. In contrast, succinylcholine results in hypertension and tachyarrhythmias. Prolonged paralysis, typically tetraplegia following drug discontinuation, is unusual and results from accumulation of the drug or active metabolite or from ICU acquired weakness. The risk of ICU acquired weakness from these agents use is modest at best and may be greatest in sepsis or septic shock, severe illness or with concomitant use of glucocorticoids. Prolonged paralysis is typically related to prolonged use of these agents, often in the setting of kidney function impairment or hepatic insufficiency. So to summarize, neuromuscular blocking agents are not the first-line agent for managing critically ill patients with undesired movement, agitation or ventilator dysynchrony, since they do not have sedative, amnestic or analgesic property. Other than emergent intubation, neuromuscular blocking agents are generally reserved for those in whom conventional strategy of sedation and analgesia have failed. In general, agent selection is affected by factors including kidney and liver dysfunction and hyperkalemia. For continuous infusion, cis-atracurium is typically the preferred given its metabolism is unrelated to kidney or hepatic function. For endotracheal intubation in the intensive care unit, rocuronium is commonly used as an alternative to succinylcholine given its rapid onset and intermediate duration of action but without the risk of hyperkalemia. They can be administered by intermittent intravenous injection or continuous intravenous infusion depending upon the indication. Since complete paralysis may not be required for critically ill patients, a desired level of paralysis should be targeted. The depth of neuromuscular blockade should be monitored by clinical assessment and by peripheral nerve stimulation. Daily interruption of infusion is suggested to assess the ongoing need for paralysis, and discontinuation should occur as early as is feasible and tapering is not necessary. Here I finish. Thanks for watching this video. If you have any feedback, suggestions or comments, please write them down in the comment section box. See you soon with my next video on some very interesting topic. Till then, bye and take care.